What's going on, everybody? It's Alex here from Alex Physio. So today we're going to be chatting with Abdihamid Abdihalim, one of my good friends and also an internal medicine resident in Edmonton, Alberta. Hey, Abdi, how you doing?
I'm great. I'm great, Alex. How's it going? Long time no chat.
Yeah, I'm excited to have you here. Obviously, thank you for taking time out of your busy schedule to kind of chat with me and chat with have a conversation just about internal medicine and kind of your life on the medical side, and hopefully give some education and advice and also just knowledge to anybody listening to this and watching this who would benefit from hearing you speak. So super excited to have you here. This has been a long time coming, and uh, yeah, let's get to it. So first thing, just tell us a little bit about yourself.
It's a pleasure chatting with you, Alex. I appreciate you thinking about me and doing this. I'm happy to share my thoughts. Always happy to chat with you, and it's a pleasure being here. So a little bit about me for the audience. I grew up in London, Ontario, and I did my undergraduate degree there in kinesiology. I got a Bachelor of Science in Kinesiology and then did my medical education at Dalhousie University in Halifax. So I did a trip out east. And then after medical school, I applied to my residency and have been doing my internal medicine residency in Edmonton, Alberta. So I'm a bit of a Canadian hopper, out in Ontario, out east in Halifax, and then now out west in Alberta. In my internal medicine sort of residency, I did 3 years of core internal medicine, and I completed that this July. And then I started my subspecialty training in general internal medicine, which is a little different than core internal medicine. And I have a 2-year subspecialty training in that, which I'm in 6 months. I've started 6 months of so far. So that's a little bit about me in terms of my career. I have a interest in a broad sort of areas of health and well-being, from medicine to exercise and exercise physiology, which my undergraduate degree was in, and to nutrition. And so I thought internal medicine is sort of it was a great match for that reason.
Yeah, no, that's great. Thanks for sharing. Obviously, the road to medicine and becoming a physician is obviously a very challenging road, and being able for myself to see you firsthand in terms of how far you've come is something that you should be proud of, but also I'm super proud of you, because a lot of people don't see that grind and the effort and the work that you put in to get there. Do you want to just tell us a little bit about maybe what the most challenging part was, or what are some obstacles that you may have faced, even being an undergrad and getting into medical school, and then while you were in medical school and now being a resident? Maybe just chatting about a little bit about that.
Yeah, sure. I think with getting into medical school, most people know it's difficult, and I think I'd be sort of repeating the phrase, the sort of comments of many people in the past, to say that it's a grind. It's very difficult to get into medical school, especially in Canada, especially if you're from Ontario. But you persevere. You write your MCATs, you get a good GPA, and apply, and hopefully you're given a spot. So that was probably the most difficult sort of hurdle, is just to getting into medical school. And then once you're in medical school, it is in many ways sort of deciding on what you want to do is probably one of the more challenging issues, because once you decide what you want to do, it helps sort of ground you a little bit, and once you're grounded, I find it's easier to sort of work towards that goal. And so when I was in medical school, I sort of tried to realize that as early as I could, and dabbled in many different areas within within medicine, and landed with internal medicine. And so with residency comes a whole host of other challenges, mostly around the transition from being a student to a resident physician, the increased responsibility, the prescription pad, which in many ways is one of the most dangerous tools available to citizens, and the just the volume of work that's required to be a junior resident was extremely difficult. Probably the most difficult period of my education was my first year of residency, and similarly with getting into medical school, you sort of just grind through it, and do your best to sort of get through that difficult phase. And things certainly get better. Another reason why it's extremely difficult is the difference between clinical medicine versus medical education. Whereas in medical education, a lot of it is theoretical learning, writing multiple choice exams, whereas in the grind of a hospital environment where you're dealing with 6 patients, a lot of it is just knowing by doing. And so trying to get through that change in how one learns was also very difficult. And thankfully things do get easier as you progress through residency. It's never easy, but they get easier, and you find ways to adapt and compensate. And thankfully, now that I've finished my core internal medicine years and now in subspecialty training, I would say things are much smoother. It's still very difficult, but things are a lot smoother. And something I didn't mention, but is certainly worth mentioning, is we just went through a enormous pandemic over the last couple of years that have took a toll a lot on our medical system, and in particular internal medicine, as the vast majority of patients admitted to hospital are not admitted to ICU. The vast majority are coming under medicine, and so our workload had significantly increased, and the stress and cognitive load that placed on us as residents, who are in many ways the workhorse of the hospital, was immense. But similarly, we just sort of do our best to get through things, have some camaraderie, and thankfully things do work out for the most part. And I think for me it did. Now I'm in a much sort of adapted place in my medical training.
Another thing that I wanted to say about Abdi is he's a very humble individual. A lot of accolades, but we'll never really chat about it. But I'm going to chat about it for him. So he's the chief resident at the University of University of Alberta, Edmonton.
Yeah, University of Alberta.
University of Alberta. Yeah. University of Alberta. So obviously he's doing a fantastic job, and yeah, we're definitely going to chat a little bit more later on, just on some of the things that you've had to go through, just especially over the last few years, and being there in that time with everything going on with all the COVID stuff and the pandemic. And another thing that you mentioned, which I think is very important to mention for anybody going into any field, coming from school or from the kind of formal education piece, is how so much of the learning you get is once you actually start working. Like, you can learn all the foundation, all the theoretical concepts, but once you're actually in the field is when, the real learning starts. And I know it's similar with that in physiotherapy. When we were going on our placements, we would read about these conditions and learn about these conditions and practice, different techniques on each other. But once you actually have somebody in front of you who has that condition, that you can't really get someone to act when you're in class, just a classmate, it definitely changes the perspective, and you have to really learn to be comfortable being uncomfortable and just being in these scenarios, because that's how you learn. You don't learn you can learn the basics in a cozy kind of environment where everything is controlled, but once you're on the field and you see how the day-to-day runs, that's when the real learning takes place, and you either sink or you swim. You're kind of thrown into the wolves, which obviously residents are kind of known to be, and a lot of people know on that, just how you guys, work, ridiculous amount of hours, and there's not a lot of good pay or relative. You're not getting paid relative to what you're working, but you having to work your way up is obviously very difficult, especially in the early stages when there's so much new information, so much novelty in your learning experience. So being exposed to that is, I can't imagine how difficult that is in the beginning. Or was there a moment during when you were in medical school, that solidified that this is what I want to go into? And if maybe there wasn't a specific moment, can you elaborate also a bit more on why you went specifically with internal medicine versus some of the other specialties? Because obviously there's several different specialties that one can go into, and that's always a more challenging decision, or probably one of the most challenging decisions when you're a med student, is just which field do you want to go into. So do you want to maybe chat a little bit about why specifically internal medicine, or if there was a moment that
yeah. Thanks, Alex. Yeah, great question. I think with me, having an undergrad and experience in kinesiology, going into medical school, I gravitated towards orthopedic surgery, and I actually did some research in orthopedics, did electives in orthopedics, and I thought it was, a specialty I would consider applying to, at least fairly high up in my decision of in my personal ranking of specialties. I quickly learned, though, that I didn't really like the OR. I didn't like the operating room. It was interesting, but it really just wasn't for me. It was something that I was interested in briefly, but it quickly lost its appeal to me. And as surgeons, a big part of your training is operating. And I didn't want to be doing a surgical discipline and not operating. It doesn't really mesh. If you're going to be a surgeon, and if you're going to be in the surgical discipline, you need to operate, and you need to be very comfortable and and you need to enjoy the OR as much. And so I had friends who loved the OR, and so chose surgical disciplines. It really wasn't for me. And so that was the first sort of fork in my road that I made a decision on, whether to do surgery or medicine. And so I decided on medicine. And within medicine, or I should say not medicine in particular, but non-surgery, there are a variety of different other disciplines. There's obviously internal medicine with all its subspecialties, including cardiology and GI and endocrinology and critical care. And then there's radiology, and then there's anesthesiology. There's pathology. So there's psychiatry, there's family medicine, there's a few other non-surgical disciplines. I knew I wanted to work in a hospital setting, and I knew I wanted to do a broad-based specialty that dealt with multiple systems, and had a breadth of physiology. And so I did consider anesthesiology as well. And then I quickly realized again, in the operating room with anesthesiology, which I didn't necessarily enjoy as much. And I also realized I liked outpatient clinics and having an ambulatory care setting and managing patients' chronic diseases. And so to me, it was a pretty clear-cut sort of decision to do internal medicine. And I made that decision, I guess I would say, in the middle of my medical school training. I had, like I said, good mix of inpatients, outpatient work, broad interest base in physiology and medical care. Wasn't really interested in pediatrics and the care of children. And so internal medicine is an adult-based specialty, very flexible. You can also within internal go into all sorts of different disciplines, whether that be, like I said, gastroenterology or respirology or rheumatology, cardiology. And it has a mix of both academic and clinical community medicine. it sort of appealed to my academic nature, I would say, my curiosity. Whenever there's a rare condition, I was always one of the first people to sort of look things up and try and understand the physiology behind this condition, or learn about as much as I can. And so internal medicine really satiated my curiosity. And then I would say this, down the road, in my sort of more recently deciding on a subspecialty within internal medicine, it was again a similar process where you'd have to decide on applying to a subspecialty, and like I said earlier, applying to whether that be rheumatology or cardiology or respirology, critical care. I found myself in a similar position where I was interested in a broad array of specialties, outpatient and inpatient, and a good flexibility. And so the general internal medicine subspecialty program, which provides that 2 years of extra subspecialty training with dealing with multi-system diseases, and caring for patients who are seriously ill or in the inpatient or outpatient setting, appealed to me. And so again, I made that decision to apply to a similar, with a similar sort of frame of mind, to apply to general internal medicine, which is where I am now.
And proud of you for where you are. I mean, you're in your fourth year now, right? So you're definitely getting to that OG status and becoming a full-fledged physician.
There's light at the end of the tunnel, people.
Yes, sir. Yeah, that's great. So do you want to chat, or at least tell us a little bit about, what a day in the life looks like?
It really depends on what I'm doing at the time. In residency and subspecialty training, or just training in general, you don't really have much say as to what you're doing at what specific time. And so we do what's called block-based training. And so every 4 weeks, there's a different rotation that you go to. The majority of our training comes with what I would say ward-based ward-based general internal medicine. And second to that is probably emergency medicine consults in the emergency department. And then other than that, we have inpatient consults, which are other patients who are admitted under other subspecialties, whether that be surgery or OBGYN, and who have questions for us as internists. And then there's clinics. And then finally, I should say there's on-call services. So when I'm on my general internal medicine ward-based service, which is the most common position I'm usually in, I usually get to hospital about 7 a.m., maybe 7:30, and see the patients on my roster, not physically, but see the list of patients that I have, review them briefly, look at the labs that they've been given, look at the admission history and physical that the on-call person wrote. And then after that, around 8:30 a.m., we have our official handover that the on-call person hands over to the patients that were seen overnight to us. And then after that, typically there's teaching for our medical students or our junior learners. And along those lines, teaching can always can go for either a short period of time if patients are very sick and need to be seen, or they can go for a longer period of time. After our general teaching, usually we start our rounds around 9:30 or so. With that, it sort of encompasses just seeing every patient systematically, going through their vitals, going through their histories, going through their medical charts, their electrolyte panels, their labs in general, their imaging, and talking to the patient, examining them physically, and then making a plan for the day. After rounds, typically ending around noon, we have our lunch. Sometimes there's more teaching for our medical students or junior learners. And then in the afternoon, usually it is tasks that need to be done that were determined during rounds. So sometimes patients need procedures, whether that be lumbar punctures, whether that be a paracentesis, or patients need to be discharged and we need to talk to family members, we need to talk to allied health teams, and any other tasks that need to be done. So that's typically the ward, which is the most common area that you would see a general internist. Other places that you see us, as I mentioned, the emergency department, where we take consults from the emergency physicians for patients who are complicated and need either a admission to the hospital or any sort of changes in their medications or any imaging or any plan that needs to be done from a medical perspective. And then we have, like I said, inpatient consults, which are patients who are already admitted to hospital by a different service, and those services have questions for us as internists. And then lastly, the clinics, which are outpatients and typically begin, around 8:30 or 9 a.m., seeing any number of patients, depending on which type of clinic you're in, until about 5 or 4 p.m. And then lastly, I should say there's also the on-call service where you stay, you have your pay. Typically, as a senior person now, as a fellow or subspecialty resident, I don't stay in the hospital the whole time, but I have my pager on me, and I get calls from either the senior resident in the emergency department or the junior resident or the emergency physician, or I will also take calls from people outside of the Edmonton zone who have questions for an internist to answer. And typically those calls can happen at any point of the day, but luckily as a more senior person, I don't have to stay in the hospital anymore necessarily for that. So I have my pager on me and I take these calls. So that's sort of a broad understanding of how my day goes. It really depends on what I'm doing that month, that determines my day to day.
How often would you maybe say that, at least when you were a junior resident, would you be having to ask maybe the senior resident or even to consult higher up if maybe you didn't know what was going on or what could be done?
The good thing is, as a junior resident, you are very protected. So your junior year, your first year, everything that you do, you have to review with your senior or your staff. I should clarify, not everything you do necessarily that's on admitted patients, but every admission or consult that is seen, you review basically at the time with your senior resident. So if I'm on call overnight and there's a patient that needs to be admitted, usually I would be assigned that patient by the senior resident who's in the emergency department, and they would assign a patient that needs to be admitted or needs to be seen or consulted on to one of the juniors. And if I'm assigned a patient, I would see that patient. I would make a plan and sort of try and be as effective in my plan as possible. And then I would review that plan with the senior resident, who in turn would admit that patient under the physician that's on call that night. And then in the morning, that senior resident will in turn review that case with the staff physician. And so as a junior resident, you certainly have quite a bit of backing, and the system in a way controls for that. And so you do feel a little support, certainly very supported. As a senior resident, things change. And so as a senior resident, you in many ways have the option to call your staff physician at any point. This is during at nighttime. But I will say there certainly is some pressure to not. And, for me personally, when I'm doing an overnight shift, I would rarely, if ever, call my staff physician. And a lot of that has to do with how comfortable you are with dealing with patients and how imperative the decision that you're making is. But certainly there is a culture in the senior resident position of not calling staff people in the middle of the night. That being said, the staff physicians are always available. And if our training does dictate to us that when we do need that support, we do call them. Luckily, we do have good enough training that most of the time we don't need to call, and something can wait until the morning to be discussed formally with your staff physician.
Yeah, and I would assume that nobody really wants to be called at 4 or 5 in the morning, and there is that expectation, especially as you're working longer, to just try to figure it out on your own, or just call somebody, or just wait till the morning if it's not anything urgent. Exactly. I actually never told you this, but I actually had my first on-call shift. I think it was last weekend. So I worked the weekend, and I had this on-call shift from, like, mind you, it was only 4 p.m. till 10 p.m. But I was super nervous. I'm just like, my first on-call shift, like, I was thinking about you, and I'm just like, how do you do this? Like, you can't really do anything, because you kind of have to be pseudo prepared if anybody calls, to ask if you could come in and do a consult or figure something out. You're on after hours, so you have this pager, and I'm just like watching my pager for a period of time. I'm like, is anyone going to call or not? And then you get to that point where it's done. I'm like, man, I don't know how you guys do it when you're on call like 24 hours. And obviously for us, it was a matter of if somebody needs chest physio, then or if somebody doesn't have, they wouldn't want to have to be intubated or sent to the unit, the critical care unit. So they would call us and say, this person has a lobe collapse, or a lobe in their lung,
mucus plugging,
mucus plugging, or their lung collapse, or they just had surgery to remove an entire lung, and they need chest physio because they're post-op day 0. Are you able to come in? That's kind of, ours is very specific to only being paged under those circumstances. But I can see how tough it would be for, obviously, if there are matters that are pressing and you need to come in, but just having to be on point is very mentally draining, I would assume, because you're coming in, maybe you haven't slept for 24 hours, and you have to come in and see somebody who's obviously life could be depending on you. So it's a lot of pressure, and it's very challenging. So I can really appreciate and sympathize to an extent of how difficult that is, obviously on much less life-threatening terms. But so Abdi, tell me a little bit about maybe some trends that you're noticing with the patients that are walking in.
With acute medicine, and by that I mean life-threatening infections, heart attacks, life-threatening bleeds, medical system is very good at dealing with. And in many ways, that's how our medical system has evolved over the last couple hundred years. What we are lacking in is how best to deal with chronic diseases and improving life and health span. I think that is the future. That question is going to be at the forefront of our future in the medical system. And increasingly, what I'm seeing is patients presenting with severe, long-standing chronic conditions that are not well treated. Those include, metabolic syndromes, patients with type 2 diabetes, hypertension, dyslipidemia, stroke, CKD, chronic kidney disease, atherosclerotic heart disease or strokes. This is the bread and butter of sort of internal medicine, I would say, at least in the outpatient setting. And with our increasingly aging population, our increasingly worsening obesity crisis, and then with the COVID-19 pandemic revving all of that up into overdrive, patients are presenting with extremely poorly managed chronic conditions. And that is putting a strain on our healthcare system. And it's going to be a concerted effort by our leaders in the country and in the world, I would say, in how to best deal with this. In Canada, and we're also having an opioid crisis, and so we have patients presenting with, not just opioid toxicities, and chronic opioid use, but all sorts of other addictions. And so it's difficult. Chronic diseases and the management of those diseases are going to be at the forefront of the next, I would say, stage of our development of our medical system. And we need to figure out better ways to deal with that. And I'm seeing, and those are the major trends I'm seeing, is that these are not well treated in the community.
So Andy, what are you and your team, when you see somebody who comes in with all these chronic conditions and non-communicable diseases, what kinds of education or resources or methods of treatment are you providing? Like, is it more so just on the medication side? Is it lifestyle changes? Like, I mean, obviously there are so many resources that you have and so much time that you can spend with each patient, but what are you seeing and what are you doing kind of in that setting and to kind of try to change and help with the change of that system?
Yeah. So a large portion of our time is actually devoted to patient education. I would say a large part, given that we as specialists are afforded more time with patient care compared to our primary care colleagues or the family doctors, GPs, we certainly have more of an ability to teach patients. And when a patient is coming to a specialist, they do have a disease that warrants more detailed management. And so if a patient has type 1 diabetes and they have type 2 diabetes that's insulin dependent, or they have COPD and they need to use puffers, this requires a fair amount of education for the patient, not just on what to do and how to inject insulin and how to, use your puffers, but what this disease means. What's the prognosis? Is there reversibility? Is what would happen if they don't do what you're telling them to do? And so all of these questions we answer for patients. And that helps when a disease is explained to a patient and they understand it in their personal context. It helps them to adhere to the treatment regimens that we provide. So that's from a sort of pharmacological treatment regimens, from procedures. We inform all our patients, but there's a huge proportion of our job is to also help patients improve their general lifestyle. So metabolic syndrome, hypertension, type 2 diabetes, and dyslipidemia, these conditions are in many ways a product of our lifestyle. And there are people who are predisposed to these based off their genetic profile. And there's certainly people who have, conditions that are autoimmune or are out of their control. But a large proportion of our diseases that we treat chronically are based off lifestyle. And so we do reach out to patients and explain to them that there are lifestyle modifications that one can make. There's no point, it's very detailed with each specific patient. But the general gist of it is, good exercise, good diet, sleep well, the general things. And they're tailored to each patient. But in particular, what I'd like to do, and I like to help provide our patients, is reach out to our allied health colleagues. So I'll reach out to Alex Kravich and ask him to help me deal with this patient's chronic pain, who is asking for more opioids. Physicians are not the best at MSK and musculoskeletal sort of diseases and management. And so I'll reach out to Alex and ask him to help me help this patient in dealing with their chronic pain. Similarly, with type 2 diabetes, I'll reach out to dietitians. And so allied health is extremely important in this circumstance. and that is part of the sort of care I provide, in that I will refer them to our excellent colleagues like Alex Physio.
Appreciate it. I think you've touched on a bunch of good points that I want to just focus on or just pay attention to. The first thing you mentioned is just the education. And I think that's such an important piece, just to talk to people about, what's going on, why it's going on the way it is, what can be done about it in a way that they can understand. Because it's so easy to just, speak to somebody and assume that they're understanding what you're telling them. Meanwhile, they have no idea what's going on. And they come home and their partner asks them, what did they say? And you just don't know, because you were spoken to as if you were maybe a colleague, or just used terms that you're just not familiar with. So I feel like the education is super important for, for all kinds of healthcare visits with anybody, just to try to make sure you both are on the same page. Because if you're talking to them at a level where, you're talking to them as if they were your colleague, then none of that information is being absorbed. So making sure you're educating them, but also educating them in a way that they understand. Another thing that I think is important that you mentioned is just, using your allied health team. I mean, it's easy to tell somebody they need to exercise more, eat healthy, and sleep better. But, it's like the whole stages of behavior change. You can say that stuff and maybe they might be motivated at the beginning and make a change, but a lot of people need that guidance, right? They need somebody to help them along the journey, because it's very difficult to change if you've been living a certain way, not exercise, to now just start exercising because, Dr. Abdi told you to, or same thing with me, right? So we need to try to come up with a plan, a coordinated effort where there are, everybody's buying in. And, there are family health teams in Ontario where everybody has their role, and we're working collaboratively with trying to get this individual to, the dietitian is helping with the nutrition, the physio is helping with the exercise, the physician is helping with the medication management optimization, and other factors related to their health. So everybody kind of has their own role. The social workers working with the mental health barriers, psychologists as well. So everybody, if they can play a role, then that kind of at least helps to create more of a holistic team approach versus just, one person saying you need to go exercise more. And I think the other thing that's important is just how we communicate, or what you were saying on just how we communicate with individuals. Because, if we say you need to lose weight, right? Like that is probably the worst thing you can say just to approach that topic. Because as you mentioned, it's not just people are overweight because they're lazy. I mean, there may be an aspect that can improve in terms of how do we get someone to exercise more or eat healthier. But what about the people where there's a genetic predisposition, where there's an autoimmune condition? So when people just believe themselves that they're ostracized in the community because of being overweight, but people don't obviously know that there may be other conditions, well, when they come to see their medical physician and they just say the same thing that they've heard their whole lives, that's not going to motivate them to change, right? So the terms and the words that we use matter. They make a huge difference. I learned that recently, actually. One of my colleagues sent me just a kind of an educational pamphlet and tool on how to speak with individuals who are obese, just in terms of how to help them and make changes versus just saying, you're overweight, you need to exercise, because that's going to take more load off your joints. We have to pay attention to the words we use, because that makes a huge role with helping to determine whether or not somebody's actually going to make that change, or if they're just going to be like, they didn't listen to me, I'm just going to keep doing what I was doing before. Mm-hmm. Anyway, I kind of went on a rant on that, but I think it's important because you touched on a lot of good points, and I kind of wanted to just continue to add to that. So Abdi, what are you looking at when you see a patient? Obviously you're looking at their labs, you're looking at different vital signs, blood pressure, resting heart rate, different lab values, but potassium levels, sodium, all that kind of stuff. What also, or maybe can you talk further about what you look at to determine if somebody is healthy, or what constitutes being healthy to you, to your team?
So that's a complicated topic, and it's I would say difficult to answer, but I'll do my best. I will say that healthy in many ways is a difficult word to define. I think the WHO defines as a state of complete physical, mental, and social well-being, and not merely the absence of disease. So in many ways, you can be healthy, but have a chronic disease. But you could be unhealthy and not have a chronic disease. So it really, the key word is the well-being, and a lot of that refers to what's intrinsically valuable relative to somebody. So what I try to do is, as a doctor, treat chronic disease. And we have ways to treat chronic disease. We have guidelines on this. But a lot of it depends on how the patient feels and what the patient is willing to tolerate. So I have a 95-year-old patient who is taking a statin therapy to reduce their lipids. Reducing lipids will prevent cardiovascular disease in the future. But is it in the patient's best interest or well-being to continue a medication that will prevent a chronic disease that the patient may not actually die from, but die with? And so it's this difficult concept of what is important to the patient, and we try and assess that and make decisions around that. So as a physician, I'm trying, as I try and treat chronic diseases, I'm always aware that the treatment has to align with the patient's own goals. So healthy in many ways is, you know, how if a patient feels well, if a person feels well, physically, mentally, socially. As a physician who's treating these chronic diseases, I try and treat them or prevent them ideally. And in that way, preventing these big chronic diseases will help, you know, their physical health, their mental health, and their social well-being. And so it's like I said, it's a difficult question to answer, but you know, generally, you want to manage diseases as best as possible, and you want to prevent diseases, and then the rest is really how to help the patient, how to help somebody improve their own well-being.
There's similarities between what you're preaching right now versus and what we see as well, because you know, you can say it, you also have to, as you were saying, you have to align it with the individual's goals as well, right? Like with your 95-year-old patient, it can relate to if we see somebody and if they have no pain, but they came to see us because the MRI showed that, you know, they have severe OA, osteoarthritis, or they have meniscal tears, but they have no pain. Well, you know, we can educate them on what these MRIs mean and what's going on, but it's not always just about, there's so many other factors that are playing a role in somebody's overall health. So the fact that you mentioned just healthy isn't just the physical status, but it's the mental, it's, you know, it's the social, the emotional, all that stuff plays a role in their well-being. Well, if they want to exercise and they want to still run or walk or, you know, run a marathon, but they have OA in their knees or arthritis, but they don't have any symptoms or very minimal symptoms, then it would be silly of me to just tell them to stop running or doing those things that give them joy and meaning and pleasure in their lives because of this, you know, imaging that doesn't even show, or that's proven to, you know, people can have imaging and not have any symptoms, at least from a pain perspective. And it kind of relates, I think it relates to what you're trying to say, just with regards to, you know, we can manage, we can try to prevent, but we also have to look at, you know, what these individuals' goals are and how we can optimize it to improve their overall quality of life as well.
Exactly.
Yeah. So yeah, that's good points. So switching gears here a little bit, or at least I guess kind of talking about it a bit. You know, you mentioned some of these managing diseases, preventing diseases. You know, when people see their family physician, you know, you only have so much time, and what even I've experienced when I was younger, in addition to what I hear my patients all the time, is, you know, they just prescribed me some medications, and you know, they didn't chat with me about these things. And you know, for me early on, because I've had some of those experiences as well, but now that I've kind of been in the seeing how it works, or how the healthcare system works, the flip side, or seeing it from the physician's perspective, is, well, the system is designed that you can't spend an hour talking about lifestyle interventions and management with patients if you have to see, you know, 40, 50 people a day. You know, you don't have time to do that. So, you know, the quick thing is just to give them that medication. And I don't think it's the physician's fault. I think it's just the healthcare system that is just nowadays. And kind of, you know, as our population is aging, and as people are living with more chronic conditions and comorbidities, that's just the reality, unfortunately. um, what do you think the future of healthcare looks like, and what would you maybe you like to be seeing that can be changed in Canada and just in our healthcare system?
You know, that's a really good question, Alex.
Asking you the good ones, eh? Let's go.
That's a great question. It really is. It's something that's prescient in the news right now too, and the healthcare system is under a lot of strain. I think for me, if I had to point at one thing to fix, it would be primary care. The model for physicians, for the most part, in Ontario, and I think in Alberta as well, is what's called fee for service. And a fee for service model works because patients are going to be seen, because it basically dictates that physicians are paid for how many patients they see. And unfortunately, for primary care, the physicians are really limited in how much time they can spend with their patients to be able to I guess make a satisfactory income for themselves, whereas specialists and internists like myself will have a lot more time to interact with the patient and to educate the patient, as a typical consult for a specialist should take about an hour. With family physicians, you know, you're looking at 10 minutes, 5 minutes, 15 minutes. And so it's we're in a very difficult place there. And I'm not saying I have an answer to how to solve this problem, but we certainly need better primary care. I see this every day in the hospital, where patients are admitted to hospital for, you know, poor management of a chronic condition that could have easily been avoided if the primary care was better, whether that be a COPD exacerbation, whether that be, you know, a heart attack because of poor, you know, because of non-statin therapy, or that be, you know, a stroke, or, you know, God forbid, people coming in with cancers that could have been avoided because of better screening tools that we have. And so and then, you know, that is not even to say the patients that are coming into the emergency department because they can't access their primary care. And so, you know, sometimes as the internist and subspecialist and general internist, I sometimes end up doing primary care just because the patient doesn't have a primary care physician, or has a primary care physician that sees them for 5 minutes. And so I end up managing simple diabetes in general internal medicine clinic that is designed to manage more complicated patients. And so that takes away resources from patients who need to come into our clinic. And so it's this vicious loop where I'm seeing this only from a general internist's perspective, but you see this across the board among specialties. And so we need better primary care. I don't know how to solve that problem, but it needs, the powers that be, I think, should focus on this. And then along those lines, I would also say we need better support of our allied health colleagues. I didn't mention this before, but I work with a lot of physiotherapists in the internal medicine wards, and a primary reason that a lot of patients are stuck on our, either general wards, or we move to a rehab ward or a alternative care unit, is because simply they are not mobile. And we don't have the physiotherapy, we don't have as much physiotherapy support that we would like to support these patients and help them mobilize and get back to where they were prior to, or at least close to where they were prior to hospitalization, and so that they can get home and recover and do the rest of their recovery home. But unfortunately here, we don't have as much support as we would like. And, like I said earlier, as physicians, unfortunately, we don't have the education that our physiotherapy colleagues do when it comes to mobility in the musculoskeletal system. And so patients sometimes, stay on hospital medicine wards, internal medicine wards, without having any internal medicine problems and really having physical therapy problems. And so I think we need better support of our allied health colleagues. And, I think generally, the future of medicine is this. I think, the last 100 years or so of medicine was the perfection of acute care. Trauma services is very streamlined and protocolized. You come in with a trauma, and our healthcare system is excellent in dealing with you. You come in with a GI bleed or a massive clot or a life-threatening infection or a heart attack where your blood clots, where your heart is vessels are clogged. Our medical system is excellent at managing you. We need to now step back and think about what we need to adapt in terms of how to deal with chronic conditions, as the vast majority in our country, the vast majority of people will die because of a chronic condition. And not just their lifespan is shortened, but their health span is shortened. And health span meaning the amount of time you spend in good health, with good physical, emotional, and mental health over your life. And so, I think the next 100 years or so of our medical system will be devoted to perfecting this side of medicine, as we haven't yet. And so I think that's, if I were to sort of say what the future of healthcare will be like and what we need to change, it's chronic conditions and how we manage them.
You touched on some really good points. I think that definitely is the key as well. Even when you mention the family physician stuff, right? Because people are coming to the emerge or urgent care and they don't have a family physician, and that's been in the news as well. And you look at immigration numbers, there's that big 500,000 people expected to come next year, or that's the target from the government in Canada and the federal government. And you're just wondering, even from, there's so many difficulties with that from all different aspects. We can talk about real estate, but that would be another conversation. But from a medical perspective, I mean, if people, I don't know what the number is in terms of how many people don't have a family physician, but I think it's in the millions of people in Canada don't have a family physician. So now we're bringing in, obviously there's a lot of benefit to immigration. I mean, you and I were both immigrants ourselves, so we're thankful for the government for bringing us in. But you look at all these other issues that can come now as a result, when we're already struggling with so many things just within the country from a medical perspective and accessing medical care and having a family physician. And as you said, you having to deal with the things that primary care or family physicians should be dealing with if that was available, but these people just don't have that. So you're managing, diabetes in the emergency department, or screening for tests for a cancer that maybe could have been screened earlier, with their family physician, or just the protocols would have been in place prior to. So that definitely is a huge point that you brought up, and I'm happy that you were able to bring that up for sure, and just to chat about, because that's definitely going to only continue to persist as our populations continues to expand. And the other thing that you mentioned is just our aging population. So it's not necessarily just about how many years you live, but how many of those years, as you said, are healthy, or where you're relatively healthy, where you're not sure our population, or we're able to live longer now versus 100 years ago, or even 30-40 years ago. But just the fact that we're living with a lot more chronic conditions that are severely affecting our quality of life, and that are progressing into conditions where our life is compromised or affected as a result, of quality of life. You look at people who have dementia, or things that affect their quality of life, or mobility issues as well. So that's something that, if we can optimize or help to optimize people's chronic conditions, and that can play a role in their overall quality of life.
Mm-hmm.
And the last thing that you mentioned that I just made a point on, first of all, I didn't pay you or tell you to preach about physiotherapy or anything like this. So this is just a disclaimer to anyone listening. Your words kind of on the therapy services, but I do find that while working in the hospital as well, on the inpatient floor, even with our own kind of orthopedic colleagues, sometimes it would just be, mobility is something that is difficult to understand or see until you're actually working and just looking at our perspective versus kind of the medical piece. So for example, people will have a surgery, an elective surgery for, let's say, an orthopedic condition, and they'll say, this person can go home. But the issue, and they're saying, just wait until we or let us see the patient and then discharge home. But they already have the discharge paperwork ready. They're to go home. The issue with that, though, is what they see on paper is this person's 40 years old. They're mobilizing relatively well at baseline, so they should be fine. But the problem with that is they don't look at it from our lens, and the fact that, no, this person isn't fine, because even though they were moving well and they're young and all that before, they have these chronic conditions that you were mentioning that, if they've had, let's say, an ankle surgery where they now can't put any weight in the leg. Well, if they have diabetic neuropathy and they don't have any sensation, now how do you think they're going to do if they have to hop on one leg that they already have poor sensation in, because they can't put any weight on the other leg? So now they have to hop. Or what about just doing things around the house, getting dressed, showering? Who's going to do groceries? Who's going to cook if they're living, let's say, at home? So even though on paper it looks like this should be a simple discharge because they're young, they don't have any, they were mobilizing relatively well in terms of their walking without any gait aids or whatever. You have some of these surgeries, and this completely can affect their quality of life. And no, they're not ready to go home from a mobility perspective because of all these other things that maybe were just not looked at, or they just don't see it from that perspective. So, for me at the hospital, and just we do a lot of discharge planning. And even though somebody is medically cleared to go home, they need to be functionally cleared. And the functional piece is such a huge component. And unfortunately, there's times where we're seeing only 40% of the patients that are on the floor, especially when we're working a weekend where there's only one physiotherapist and there's 40 patients on the floor. Everybody needs to get moving, get stronger, get more mobile. But because we don't have those resources where we have more than one therapist working on the weekend, and there's some hospitals that don't have any therapists, so we're lucky. But there's some hospitals that have no therapists on the weekend. But people's mobility doesn't stop on the weekends. They still need to get moving and be strong and be mobile. And these are the things that sometimes tend to fall under the rug when it comes to a funding perspective. And why do we need more physiotherapists? Well, these are the reasons, because as you said, when people are living with chronic conditions and they're staying at the hospital for 20-30 days, that's $2,000 a night for them to stay, right? So that these are costs that are coming out of your wallet, my wallet, for these individuals that are medically maybe stable, but because of all these habits and issues that have built up over such a long period of time, they're not as strong and is not able to recover as quickly after whatever surgery that they had. It can be orthopedic, but it could be a surgery that you have done or played a role in, that's limiting their ability to progress to their function baseline, because their baseline wasn't even that strong or functional to begin with, because they were already struggling with all these other health conditions contributing with their mobility. So anyway, I went off on a rant, but hopefully that could kind of we can, or at least Abdi, you and I talking about this can kind of bridge that gap, or that area that where the comprehensive care and looking at it, everybody has their own roles. And I feel like sometimes there's a tendency for, I'm not saying you, but just in general, the physicians and
people become
doctors to say, oh, we did the surgery went well, this person can go home once they're cleared by physio. And then when we say no, they can't, then we're sometimes made to be the bad guys because we're the ones holding up the discharge. But it's like, hey, they can't go home because they're going to have a fall or something's going to happen, and they're just going to be readmitted back again, right? So we have to work on them, give them this education. Maybe they spend a day or two, but that's the difference between them going home with more confidence and more reassurance in their abilities that they can continue to progress, versus them going home and possibly being readmitted to the emergency department. So there's definitely a lot of gaps that we need to work on as a healthcare system to try to optimize the health of Canadians, right?
Exactly.
What are some things that you're doing on your days off other than chatting with me and creating these little podcast videos?
Oh, that's a good question. On my days off, I'm just like everybody else, just watching some Netflix or and watching some TV. But I do love to travel, to be honest. Whenever I have like a chunk of time off, a week or 2 weeks, I always like to get out of the country and go somewhere new and pick somewhere that I'm going to go and pick up and go there. So I've traveled quite a bit over the last few years. Even during the pandemic, I was able to at least get out a couple times. Other than that, I like to read quite a bit. I like to consider myself a history buff. So I have a particular interest in reading about history and more recently the history of medicine as well. I did a few presentations on the history of medicine. I was part of the History of Medicine Society in my medical school. So that is an interest of mine. And my spare time, I'll read quite a bit about random, tidbits on the history of medicine and history in general. And sort of the world history in particular, but anything history, I'll consume. So that's sort of an interest of mine. And then playing sports, kinesiology background, as you know, I like to box. That was an interest of mine. So I still do that here and there. And play some sports, some friends. So that's sort of on my days off. I try and relax quite as much as I can. We work hard, but you need your personal time and rest, and you can't always be learning and doing new things. Sometimes you need to just take a little bit of a break and sit back and not do anything really.
Abdi, also, I told you you're a humble guy, and I'm sharing it with everyone. But you were one of the top boxers in Canada when you were younger. For everybody, if they don't know, but he was definitely a boxer back in the day, and still could probably knock me out pretty quick. So Abdi, what would be maybe one piece of advice or something that or a piece of advice that you would give to somebody, based on just the hundreds of people, the thousands of people that you've seen over your career, just in terms of, things that they can do to be healthier or maybe to be in a position where maybe they don't see you at least for a couple of years, or a medical professional if they're kind of doing their own thing? What's one piece of advice you would give to somebody watching this, and a take home message that you can give?
I will say that that's another difficult question to answer, but I'll do my best.
I didn't prep you for this one. My bad.
I won't. No, that's fine. It won't be. I won't give you a cop out answer. I'll try not to, at least. I think there's no quick fix to anything, right? And I also say that there's a big difference between health optimization and medical care. Medical care is what I do as a physician, as an internal medicine physician. I care for patients with chronic diseases and acute conditions, but generally in the outpatient setting, chronic conditions that I'm caring for. That's medical care. Health optimization, on the other hand, is somebody without any real chronic medical condition that needs treatment from a physician, but somebody who wants to get healthier or optimize their physical well-being, optimize their mental well-being, optimize their emotional well-being, their cognitive well-being. And that is actually a different realm, I would say, than what modern medicine even encompasses.
Sure.
So in many ways, it's difficult for me to answer that question because it's very, particular and detailed to the specific patient, to the specific person, I'd say, as they're not really a patient in that sense. It's very personalized. But I will say that generally, what the things to sort of think about with regards to being healthy is keeping things simple, right? Having a diet that's not filled with fast food and minimizing the amount you eat. Exercise daily, sleep regularly, and have good sleep hygiene. And then if you have those three as sort of the general things that you do, and then with your actual primary care, have appropriate health screening. That's something that we do very well in the modern medical world, whether that be cancer screening or diabetes screening or lipid screening. Know your family history, I think, is something that unfortunately a lot of people don't focus on. But if you have a family history of early heart attacks, you have a family history of inflammatory bowel disease, if you have a family history of strokes, these are important things to know, as it will decide on how you screen as an individual. And then other things like avoiding smoking, alcohol, and keeping your mental and physical well-being, or mental and emotional well-being in check. These are generic statements, I understand, but I think they go a long way if you keep it simple and you abide by these sort of general principles. At the end of the day, like I said, there's no quick fix, and I will say this though, and there's the evidence to back this up, is that the single most important tool to improve your overall health is exercise. There is no drug or procedure or anything that in the modern medical world can provide you that exercise can't. Exercise by far, and that's daily exercise, will provide you with excellent health and health and well-being. And then, lastly, I will also say, that lifespan and health span are very different, and having those things in mind is also helpful. Lifespan, how long you'll live. If you live to the age of 80, that's your lifespan. Health span, on the other hand, is how long you live with good health that is adequate for you. Most people in their 80s or 90s are not in a good health span position, in that they maybe can't move, they maybe have dementia, maybe they're wheelchair bound, a whole host of chronic conditions that have debilitated them to the point where their quality of life is severely impaired. And so having a good health span and focusing on that is, I think, extremely important. And one of the earliest signs of poor health, or what I would call the canary in the coal mine for poor health in many ways, is physical pain and physical musculoskeletal exoskeleton problems, whether that be knee pain, back pain, etc. And so by that, I mean, long before you develop dementia or cancer or fatty liver disease or a heart attack or a stroke, one of the earliest signs that you're in poor health is that you have these debilitating physical conditions. Your knees and your back are in pain is because you probably have poor metabolic health and are overweight. And so the first thing that you'll notice is that physical distress. In many ways, Alex, this is where you will see patients and sort of deal with the repercussions of that poor health. And then with that physical pain becomes a vicious cycle, which eventually leads to the major pillars of chronic disease, which are, like I said, atherosclerosis, cancer, neurodegenerative disease, and metabolic syndromes. So it's a long-winded answer, Alex, but I think having a general sort of interest in keeping yourself healthy and an understanding that the lack of a disease or a chronic disease does not necessarily mean that you're healthy.
Those things that you mentioned, I know the sleep, the eating healthy, the exercising. The other thing I would touch on those three, not to speak for you, but just to kind of add to what you're saying, and what I would assume you would add to it is the consistency of that, right? Because you can sleep well, for a week, or you can exercise for a week, 2 weeks, a month, 2 months. Same thing with eating healthy, but it's that consistency that's going to make the difference, right? Because your body will be okay if you eat junk food for a week, but if you make that a daily, monthly, yearly thing, then obviously that's when those changes, you're going to start to notice it over time. But having the consistency to exercise when you don't feel like it, when you're tired, eat healthy and meal prep or make your own food when you want to just buy fast food. Those daily deliberate decisions are going to be the difference between, or are going to at least increase your chances of being able to increase, as you mentioned, the health span versus just kind of focusing on the lifespan. And I really like that lifespan versus health span. I never thought about that, or I never looked at that, or knowing the terms and how it's associated, but I really like that. I learned that. And even I learned about, you mentioning the family history. I think that plays a huge role too, knowing what your family history is. And again, something for me personally, I never really thought about, but obviously that plays a role as well in seeing where you stand. Because obviously, from a genetic component, family history plays a role in what conditions may suffice or pop up in the future. I'm super happy that you're able to join, and I'm really looking forward to seeing where your career goes. And I know you'll be an amazing physician and an internal medicine doctor. So thank you again so much.
Thanks, Alex. Appreciate this. Let's do it again sometime.
Yes, sir.